Thank you. In 1948, copies of leaflets like this were dropping through letterboxes up and down the country, announcing the creation of the new National Health Service. Something that would be free for everyone, universally covering every person in this country, taking away money worries that people used to have associated with getting healthcare and getting ill. This is Nye Bevan, the Minister of Health at the Services Foundation, not far from here actually, on the first day of the National Health Service, 5th of July 1948, he visited patients at Davyhulme Hospital, which I think is not that far from here. And since then, 97% of the babies born in England have been born in National Health Service care. And quite a lot has changed. We're all living longer, healthier lives, or many of us are. Medicine has been transformed in the 70 years since 1948. The way treatment works, the way hospitals are configured, many things have changed. And we're on the cusp of a new revolution with genomics, with artificial intelligence, with personalized medicine. So we have a lot to do. I work for an organisation called NHS Digital. We're the digital data technology partner for the health service in England. Those services are devolved in Scotland, Wales and Northern Ireland. So we serve around 53 million patients and members of the public across England, 1.3 million health and care workers. So we're not the world's largest employer. The Chinese Red Army and the Indian National Railways outnumber us. But we are the world's largest employer of skilled professionals, doctors, nurses, allied health professionals, and increasingly technologists, designers, all the many different professions needed to keep the health service moving. We also work providing data for vital medical research for the research community, using data from this massive data set of health and care across England to inform the search for cures, for new disease, for understanding disease better, for finding new cures. And the wider community, so the third sector, volunteers, family carers, all of the people who support patients and the public when they're ill and when they need care. And so it's a massive audience, a massive group of different stakeholders and users that we serve. And this is some of our team. Took this picture when some of the team were helping to recruit our next generation of user-centered design graduates who are going to be starting at NHS Digital in September. I'm really excited that we're able to bring in a new generation of talent and develop our own skills inside the organisation. This is just some of the team. We've got about 23 interaction designers, 10 service designers, 5 graphic designers, around 40 user researchers, content designers, product managers, delivery managers, developers, which feels quite a big team, but also when I think about the scale of the challenge, also quite small. So we need some help, and I'm hoping that many of you in the room, either as working in agencies and suppliers, or working perhaps with many of the different health organisations and care organisations in the country, you might be part of the solution to that gap that we have. So I'm going to do 3 things. I'm going to show some of the work that we've been doing. I want to talk about what we're learning about the experience of care, what's it like for patients and the public and for staff using digital services in the NHS today, and how we're working to improve those things. And then also share some challenges, so I can talk about some of the things that I think we need to crack in the next 2, 5, 10 years as we look ahead to try and make the National Health Service sustainable and relevant for the next decade, for the next 70 years. Show the thing. So a year ago, if I'd shown you the National NHS website, you'd be looking at something that didn't work very well on mobile devices, certainly had a large number of accessibility issues, and was hosted mainly on Microsoft SharePoint 2007. Everyone laughs when I say that one. Today we're on an open source modern content management system. We have fundamentally a mobile-first approach to the design of the service. We are working through a long backlog of accessibility issues, making things better and more inclusive. By no means are we there yet, but we know what we need to do, I think. But critically, the role of the website is changing, because historically the NHS website, NHS Choices, was a kind of health encyclopedia, vast amounts of content about symptoms, conditions, and we're moving to a time where people go online and they access information, not just for information, because they want to do something. So how do we link that information with more actionable things like finding the NHS service that you want, booking an appointment, accessing a GP, getting hold of your prescription information, getting the things that are actionable, that allow people to do something for themselves. We work in user-centered, agile, multidisciplinary teams in iterative ways. We believe strongly in the power of user research, and this won't be the first time I've linked back to what Jared Spool would have said this morning, but that 2 hours every 6 weeks of getting your team and everyone in the team exposed to primary user research is really important to us. We really believe that user research is a team sport, and also that, particularly given the stuff that we're working on, it's really important that we make services that are accessible, that are inclusive, and so we try to include people with access needs in every round of user research. We also will run some rounds where we're specifically only recruiting people with access needs, because for some services that's the reality of who our users are. And I want to share a comment from a user research participant a few months ago in Leeds, where we did a study with people who have Parkinson's disease, because it was important for us to understand a range of different access needs. And the participant who I'm quoting from now had both a motor impairment and a visual impairment. So his Parkinson's disease gave him eyesight problems, but also made it harder for him to manipulate things on the screen. And he described in quite painful detail the trade-off that he had to make on a daily basis when a website wasn't usable for him, where he could, to read better, he might zoom in, but then he zoomed in and so he's got fewer words on the screen, and so he has to now pan and zoom around the screen more so in order to be able to see the words that he's trying to access. And then he said this, which really struck home. He said, when a link is too small or a button's too fiddly, it's doubly depressing because it reminds me of my condition. And I thought, nobody goes to work at NHS Digital every morning wanting to make someone with Parkinson's disease feel worse. But that's what we do when we inadvertently make something that isn't fully accessible, isn't inclusive, hasn't been tested with people who have access needs. And in that quote, I think is also in microcosm the range of user needs that we see across health and care. And I have Janet Hughes to thank, who's in the room. Is Janet in the room? Yeah. Janet's there. Thank you, Janet, for distilling this down so brilliantly. Because Janet did some work with us and sort of framed this and said, look, people have clinical needs. So everything that we do on the NHS website has to be clinically safe and accurate. We have clinicians, doctors, nurses, midwives embedded with our teams, often helping to create the content directly to make sure that everything is safe and accurate and effective. There are certain types of treatment and services that you won't see on the NHS website because there isn't an evidence base behind them. Everything we do will be clinically safe and effective. But the safest service would be one that nobody used. And unfortunately, I think in the past, the NHS might have created some of those. So it also had to be practically useful. If we know that more than 70% of our users are visiting our services on mobile devices, we need to design mobile first. And then it has to be something else. It also has to be emotionally engaging and meet the emotional user need. So if somebody goes to the NHS website trying to understand what to them is a very urgent health problem, and they read our clinically safe, accurate, up-to-date information accessed on their mobile phone in a nice mobile responsive way, but if at the end of that they're still not sure what to do, or they haven't been reassured, they will probably still phone us up on 111 or on 999 or go to accident and emergency or book a doctor's appointment, because we haven't met their user need if we don't also meet the emotional need. So in everything that we do, I think we see these patterns playing out, and I'll give you some more examples of that as we go through. First one's really simple. Paracetamol, one of the most common painkillers. The old NHS website, NHS Choices, had a page of comprehensive information about paracetamol. But when we researched the page with members of the public, there was one group in particular who had a problem with it, and that was parents with small children, because the old page mixed together information about paracetamol for adults with paracetamol for children. And parents were worried that, particularly, you can imagine the scenario in the middle of the night, perhaps not fully focusing, they might accidentally read the wrong information. So the team worked on the problem, they worked around and came to the breathtaking conclusion that the best thing to do was to create a new page about paracetamol for children. Because sometimes, the simplest solution is the best. So now it's still clinically safe and accurate, hopefully safer. It's meeting that practical need, because we're now going where the user is thinking, are they trying to find out about paracetamol in general as an intellectual exercise, or are they trying to actually work out how much to give to someone? And it's meeting that emotional need, because now everything on this page is the stuff that you need to know as a parent or a carer thinking about giving paracetamol to your child. So we're able to bring together those dimensions and hopefully now empower someone to give some simple medication that will make things better for themselves or their child, but also avoid the need to go and access a service where they don't need to go, don't need to get up and out in the middle of the night and go and access that service. Some of the things we do might look kind of superficially simple, but then there's a deeper complexity. So this is the 111 online service, where you can go onto the NHS website or on the NHS app. You can answer a series of questions about a condition, something that's worrying you, and at the end it will tell you, how serious, based on the questions you've answered, it might be. How urgently do you need to go and get help? And also, where could you get the right kind of help for the problems that you've just described? It's a kind of choose your own adventure of illness, right? A set of branching questions and answers, and on the back of that, a disposition, what to do next. The thing that makes this complicated is that depending on your answers, an ambulance might be dispatched. And so it's that link from the information that someone gives us online through to the services that are delivered across the National Health Service in different localities, commissioned in different ways. It's the link to making sure that information about the patient is in the hands of the ambulance crew when they go out on that call, so that they can give the best care. And it's lining up all of those things so that we get it right first time and don't ask patients to go through multiple access points until they solve the problem that they were trying to solve. So we've been doing some work, particularly with FutureGov, doing some work around 111 online and around urgent and emergency care as a wider thing, to understand what are the digital opportunities for us across the whole of that space. How can we make the health service digitally more effective when people have an urgent need or when it's an emergency? I promised you more Jared Spool. So this is my go-to definition of design. So I was amazed, really honoured to be standing on the stage where Jared was only a few hours ago. Because I spend quite a lot of my time explaining design to people who aren't designers. And I always come back to this: design is the rendering of intent. It's a wonderfully economical definition. Without rendering, intent is a great strategy. We have lots of great strategies in the NHS, but how do you make it real? So you need that rendering side. And then without intent, well, rendering might be fine art, it might be fun, but it's not going to get you where it needs to get you to. So from the start of my time at NHS Digital, I've always challenged our designers, our user researchers, to always be able to talk about the intent behind what you're trying to do. If we can't start a show and tell presentation explaining why we're doing this, we probably shouldn't be spending any more time and effort on it. So start by understanding the intent, but then have the craft skills, have the capability to make that real and turn it into something that really solves the problem. Quite often, we think of needs, user needs, in this kind of linear way. And again, I'm feeling some of the pictures that you saw this morning might also be echoed in this presentation. It's not as straightforward as, I have a problem, I look on the internet, I take a paracetamol, my headache goes away. Because actually, when we do research, it tends to be a bit like this. There are ups and downs, there are emotional highs and lows, there are moments when people need more support than when they need others. And unfortunately, there are also these sort of knots and joins and bits where siloed services don't quite work together. And so the experience of care can rapidly become a little bit disjointed. And it's either the frontline workers who join the dots and make things work for patients, or it's patients and the public having to sort of puzzle it out for themselves, which isn't right. And then we find that a lot of experiences aren't linear at all, they're cyclical. So when you get a repeat prescription, or if you have maybe a condition that's seasonal that comes back at the same time every year, or just the general experience of keeping well on a day-to-day basis, there are things that you do over and over again. You have an opportunity to learn about your own health and well-being, you have an opportunity to sort of understand how services can work because you encounter them over and over again. And so understanding where experiences aren't just a linear beginning, middle and end, but actually are loops and cycles is one of the keys, I think, to being able to deliver a much better experience of health and care. And the other pattern that we see is this kind of layers. So the work on urgent and emergency care is definitely bringing this out. It could be that someone goes to one access point, gets some help, but then is referred on somewhere else, or it could be that the first time their problem wasn't quite dealt with, so they went back again. Seeing these lovely experience maps that are just layer after layer of and eventually we get it right. Sometimes that's the right thing to do. It's because a second opinion genuinely was the thing that was needed, or it was because a referral onto a specialist was the right thing to do. Other times it's because we didn't quite get it right first time as a service. We didn't point someone to the right place, or we didn't have the information that we needed to have. And that, to me, looks like waste. It looks like something where, as designers, we ought to be challenging it and saying, well, couldn't we have answered that patient's problem the first time? So Tero, our lead service designer, has been audaciously making a map of the whole experience of health and care, trying to look at which bits of that health and care environment and landscape are cyclical and which of them are more linear transactional services. So you'll see the cycle of managing my well-being. We want to spend as much of our life as possible in that circle, staying well, not having to worry too much about things. But then something might happen that tips you into one of these sort of more linear experiences of finding out what the problem is, getting a diagnosis, managing, getting having some episode that needs urgent care, an acute episode, and then recovery. And then for some people, for a growing number of people, there's a cycle of managing a long-term condition. And increasingly, because people are living longer with these conditions, multiple long-term conditions, and the interaction between them. And at that point, again, the learning really kicks in, because it's the patient often who is the expert in their unique combination of medical conditions. So while the health service is here to help and there to support them, over time we speak to some patients who are undoubtedly the world expert in being themselves, both in their health condition but also in the way they live their life and the way they've adapted life to fit around the conditions that they're living with. And then there is a bubble at the end which will take us into end-of-life care as well. So ultimately, all of us will die. We'd like to think that will be a long time away, and that people will be well looked after in end-of-life. So there's a whole cycle there that people might also fall into. And so stretching those things out helps us to try and understand what's that overall experience, a user experience map that lasts literally a lifetime, from the cradle to grave, from birth all the way through to end of life. Here's a sort of mapping example from a team who worked on type 1 diabetes. So they worked with both patients, people with diabetes, but also with clinicians. So the pink sticky notes there are insights from user research with patients, and the green ones are insights from user research with professionals, clinicians who look after people with type 1 diabetes. The team mapped the whole experience from not even knowing that you've got a problem to some sort of trigger which starts people thinking, well, maybe there's something wrong, I need to get help for this, through getting a diagnosis of a potentially life-changing condition, and then starting to become more confident in managing that condition, and then getting into potentially, we would hope, many years of managing the condition successfully. There are things that you have to do, appointments that you have to go to, but you could live a very long and relatively healthy life with type 1 diabetes if it's caught early enough and you get the right treatments. So they looked at the whole end-to-end journey. They looked at the emotional highs and lows through that and where people needed most help. And they came to the conclusion that there was one point in that journey where we, as the digital bit of the NHS website, could help with most. And that was the bit just after someone had got a diagnosis. So again, the old NHS website had some great comprehensive information about diabetes, and it was structured the way doctors think about diabetes. You know, the different types of diabetes, these are the symptoms, these are some of the treatments. This is how diabetes works medically. But now we've moved from thinking about diabetes the way that clinicians think about it to presenting it on our website the way that patients experience it, which is in stages, which is in that going through that journey. And we gathered together just a few pieces of information that people told us that they really wished they'd known in those first few weeks and months after getting a diagnosis of type 1 diabetes. It uses video because some people prefer that to reading vast amounts of text. It sort of progressively discloses the stuff that you need to know as you go along. And we think that structuring information this way is really a key part of giving power back to people who've been disempowered. It's very easy in health and care for people to be disempowered, even people who are at the top of their game in other bits of their life. Being ill is just disempowering. Disability can be disempowering. Worry about being ill can be disempowering because we know that stress is actually a cognitive impairment. So when we think about access issues, one of the things is people who are just not very well and not very with it right this minute because of their illness or because they're worried about being ill. They might not even be ill, but they're worried about it, and that becomes an impairment. So the whole lot of reasons why illness and health problems can be disempowering, but then also sometimes as the NHS, we've designed things in ways that takes power away from people accidentally. We didn't mean to, but the way we set up services, when we make them difficult to navigate, when we make them impenetrable, when we require special knowledge or jargon to get your way around the service, we've disempowered people. So we need to stop disempowering people by making things simpler and understandable and structuring them the way that people think about them rather than the way that our professionals think about them. We need to design for the positive role that people have in managing their health and well-being, for what people can do, for their assets, as well as thinking of it in a deficit model where it's always about fixing the problem. We need to involve family and carers, make sure that we're addressing people and involving them in the co-design of services, because again, it's the people are the experts in their own health and their own lives, even though we have this amazing skilled workforce of medical professionals who can help to serve them. This is Hastings at dusk, where some of our team on the widening digital participation programme went to work with people who are homeless to understand how digital health services could help people when they're homeless. Many of those participants have smartphones, had access to devices. Their issues were more around connectivity, around skills and awareness of what they could do. So by working with third sector organisations that are supporting homeless people, we're starting to try and make sure that no one is excluded from access to these new digital services. And we need to move up a ladder of participation. So as UX professionals, as user researchers, user-centered designers, we're very good at involving users as users, at doing the usability test to make sure that the thing works for the user, one individual in a room, on a phone, or looking at a screen. That's really only step one, because quite often the beneficiary of the service isn't the direct user. So there are services that are used by pharmacists, services that are used by clinicians, but they still have a patient who's the end user of that service, the beneficiary of the service. We need to involve them even when we're not designing something that's going to be used directly by them. Families play a key role. It's very rare in my user research that when we bring people into the lab, it's very rare not to hear someone bring in a story of a time they helped a family member or a family member helped them when they were ill. So thinking about user research beyond the individual is really important. Thinking about the role of communities and thinking about the role in decision making, not just passive consumers of health services, but also making decisions about people's own health and care, making decisions about their family, making decisions and sharing in the decision making about how the health service works in communities. There's a ladder of participation, I think, that starts with user research and user needs, but by no means ends there. I want to talk a bit about how we've done that working across a massive distributed system, because people see the blue NHS logo and they think we're one thing, and in fact we're many different organisations. And even within those organisations, many different teams working on different services. So it was really important that we gathered together a set of good practice, some shared design patterns and standards. But before we could converge, we had to diverge a bit. Because when I first joined NHS Digital, I was worried that we were in danger of prematurely optimising on a set of design patterns that hadn't been tested in enough different services. We had some things that had come from some good work on content pages and one or two forms, but nothing that really fully explored all the different kinds of services we worked on. So I made myself unpopular as a head of design by asking designers to go away and keep working on their own problems for a little bit longer. And by doing that, we were then able to identify where were people most at need, what were the common patterns, and then bring it all together. So there's a big synthesis day here where we printed out different work from different designers, started to identify what were the things that were working, what were the things that could come together into a shared library. So now we've got open source code, a front-end library for the National Health Service website, which is being picked up and adopted by lots of different teams outside of our own organisation, in localities, in other national organisations. We've got content style, we've got UI styles, components, we've got design principles. We had to combine the best of the gov.uk design principles, which are brilliant, which I thoroughly recommend, but also bring something of the NHS values to play as well. So you'll see at the top of our design principles, put people at the heart of everything you do. which is a principle that comes from our constitution. But then you'll also see some of the GDS.gov.uk design principles coming into play as well. And it's been a delight to see some of those appear on walls, in photos, in social media, in teams that we've never talked to directly, but they came to the service manual, they found them, they felt that they were useful to them. They've not been mandated to use them, but they've picked them up and started running with them. And so it feels like we've got a kind of a groundswell of interest and adoption of our front-end code, of our design principles, of our patterns and styles that will take this out across the National Health Service now beyond the small number of national teams that are working on things like the National NHS website. So I've got a short video of the NHS app because I want to show you how some of that work then meshes together, where multiple teams have worked on things and then we bring it together into an app. So on the 5th of September, or 6th of September last year, at the NHS Expo, big exhibition in Manchester, the Secretary of State for Health and Social Care, Matt Hancock, stood up and presented some of the work we've done on the NHS app. And he said this, which is good, right? Because you want your minister to like the things that you've made. He said, I like it. And then he said something which had our lead user researcher, Rochelle, punching the air at the back of the room. He said, I like it, but more important than that, the design has been led by user testing and user research. And that was sort of for us the starting gun on a new technology vision and strategy that you'll see rippling through the NHS today. We have a bunch of principles, but for everything we do across health and social care now, we expect them to be based on user needs, on privacy, security, openness and the interoperability of systems wherever they come from. And I'm really proud to say that inclusion has gone in there as our fourth major principle, because the NHS is for everyone, and we recognise that if we don't meet those needs, we're not meeting the needs that the service was set up to meet. We have a long-term plan which has a whole list of things. I went through the NHS long-term plan and I pulled out all the sort of verb-based kind of Lou Down style good services are verbs services. And there are dozens of them, the patient-facing ones, but also the kinds of services that we're going to offer to clinicians and people who serve those patients. And by the way, genomics. There's like every line in the long-term plan has something that looks like it's a massive piece of service design. And a set of principles that we want to be more proactive in providing services. We want to be more personalised, because that's not something that the NHS has been well known for. We're very known for being universal and providing great coverage to all our population, less so for providing a personal service to people. And critically, we want to be more joined up. And this, I think, is the big challenge for us right now. If you think about all those different services, different bits commissioned in different places. 19% of adults in the UK have experienced what's called a care coordination problem in a 2-year period. That's like a missed test result, an appointment that wasn't booked properly, some information not being present when the clinician needed it to deliver care. All those care coordination problems. And actually, we're not that bad in the international rankings. 19% puts us pretty, is a pretty good score out of the 11 countries that were in that Commonwealth Fund survey. But this is less good, right? 37% of low-income adults experienced a care coordination problem. So here we are, here for everyone, this universal service that we're really proud of, but we aren't yet getting it right for the whole of our population. And the people with the least capacity are often the ones who are experiencing it most. So it's a clinical safety issue sometimes, it's definitely an equalities issue, and unfortunately, technology that doesn't work right is also now a workforce issue. So you may have heard that the NHS needs more doctors. I've heard stories of GPs timing their early retirement to coincide with the introduction of a new computer system in their surgery. So just at a point when we need every doctor we can get, we need technology which is a joy to work with, that makes people feel like that it's supporting them in doing their job, not something that makes their lives harder. In the United States, there's a whole profession grown up called the medical scribe. There are people whose sole job it is to sit next to the doctor and look after the computer so the doctor can look after the patient. Now, that doesn't sound like a very efficient way of using technology to promote better care. So I think we've got this paradox, right? It's not a contradiction to say that the service needs more money, but that also there's still quite a lot of failure waste. We could do better with what we've got if we had a better approach to the way we use technology in the service and the way we design. We need innovation. Genomics, artificial intelligence, personalized medicine are coming our way, and we want to take advantage of those amazing breakthroughs that science is bringing us. But at the same time, we need to get the basics right, because if we don't have information in the right places at the right times when people are delivering care, none of that other stuff will help. We need everyone to be a designer, but also this is no job for amateurs. And I think if you want to come and join us, I'm sure many of you are already working in health and care. The first thing I want to say is just be careful, because a sense of mission is not enough. We do get, every time I do an interview, I've interviewed quite a lot of designers applying for jobs in the NHS over the last 2 years. I can think of one in that time who didn't tell me how excited they were to come and work for the NHS. And it's great that people have that sense of mission, but I worry sometimes that if that's the only thing bringing you in, you're going to burn out pretty quickly, because these are tough problems. It takes a long time to make a change sometimes, and just a sense of mission is not going to be enough. We need people who are also able to tangle with that complexity. Secondly, a mindset is not enough. So I see a lot of really good application of design thinking, co-creation, idea generation, and then it's such a shame because the ideas are then let down by poor execution. So we need to have the sort of design craft skills to be able to come up with good things using that design thinking mindset, but then have the service design craft skills to be able to turn it into a reality. So I mean things like communicating complexity. How do you show the vastness of the problem but make it understandable to people? How do you rapidly prototype different solutions and experiment with them? How do you do that when you're working across multiple channels, some online, some offline? How do you design with data? Because doctors don't trust anything unless it's got evidence behind it, right? We should, as digital practitioners, be there with all the evidence ready to hand. And you need to think about the pacing. Are you working on a service that needs to work instantly because this is an urgent situation that needs to be resolved in the next 5 minutes? Or are you working on something that's a condition that's going to unfold over a lifetime, where someone's going on a journey and needs a little bit every few months to be able to get to grips with something? Service designers, I think, are really well placed to bring those skills that have been missing in parts of the health service. So this is the e-referral service, where our team mapped the journey of getting a referral from a GP. When your family doctor refers you to get help from a specialist or a hospital appointment, people get a referral. And they map this journey, and Pete, the designer there in the shorts, talked me through this massive service map, hundreds of sticky notes on the wall. And he stopped at one post-it note and he pointed at it and he said, that's where we could use AI to help a clinician be confident that they're making the right recommendation. And I really like that because it struck me that, yes, we want to use this technology, but we can only do it if we fully understand the whole experience that we're introducing it into. And when we've got designers and user researchers who understand that whole picture, they're really well placed to direct the technology in the right ways. I've been hearing a lot recently about voice interfaces and chatbots and how they can be used in health and care. And I think that there's some really exciting things being done, some interesting experiments. But I kind of think that those fashions for interface technologies speak of something deeper. They're telling us that people want to have a conversation with their service. It's not necessarily because they want to use natural language processing, it's because they want a service that is responsive. And that's the hard work of service design that we've got to take on. Not knowing how to slap a chatbot interface on top of an existing service, but how to make the service itself configured to be more responsive and personalized so that it can deliver the intent behind the chatbot, not just render the basic reality of it. We've had to create the space for design to work in the NHS because this is not a greenfield site. It's a place where there are already lots of opinionated professionals who have ways of solving problems. And they're great, and we want to work with them all. But when you're introducing a new methodology, or introducing service design for the first time, you have to create the space for those service designers to do their work, and then hold the space open when people are getting impatient and saying, what are these people doing with post-it notes? Why aren't we seeing any evidence yet of success? Because it's going to take time. And a design leader's job sometimes is just to hold the space and defend that space for the team to do its work before it comes through. And finally, I've been thinking a bit about what would a user experience strategy look like at the scale of health and care. And that's not which fonts do we use, what colors do we use, how do we do our front-end design. It's big questions like this. It's how do we move authority for design decision-making to the places that are best placed to make it? So who knows where is the best place to make these decisions? Is it local? Is it national? Is it somewhere in between? How do we get the right design skills and capabilities in the places where decisions are being made? How do we treat technology as an enabler of good experience rather than something that is driving its own agenda and then experience has to be layered on top? How do we align the incentives when systems are being bought and sold? How do we align the incentives of buyers and suppliers with the needs of end users? Because quite often the end user isn't the one that's making the technology buying choice, but their experience is dependent on the choices that are made. And how do we integrate user-centered design with the wider movement for quality improvement across the whole of the health service? Every day there are people managing services in hospitals and doctors' surgeries who want to make things better. If we believe that user-centered design is something that can help them, how do we get out there and make sure that they're considering these methods and using them to genuinely improve the health service day by day, week by week? So I want to end on a quote from Nye Bevan again, because Bevan, I think as a politician, had this wonderful capacity to see into the future and see human progress in a dynamic way. So right back, even before the service started, he was making a speech to the College of Nurses, I believe. And they were challenging him, saying, Minister, you haven't given us enough resources to make this new service a reality. That sound familiar, right? The NHS never has enough money. And Nye Bevan said this. He said, "We shall never have all we need. Expectations will always exceed capacity. The service must always be changing, growing, and improving. It must always appear inadequate." So now today, 70 years later, I've got these kind of yellowing, dog-eared pieces of paper from 1948. But the intent is still the same. And we're still here 70 years later with a service that is always growing, changing, and improving. And I hope that you will be inspired to play some role in helping us do that. Thank you.